My official title is I'm the Director of Addiction and Mental Health Systems. I am a gubernatorial appointment, and I came into the government workforce about, gosh, I think it was 2014. So this is the beginning of my 10th year. Initially, I was appointed as the first and only pretrial services director. And after that was set up, we transferred those program elements to the Attorney General's office. And I was asked to take a look around and see what other portfolios matched my subject matter expertise. And the department really didn't have anybody focused on co-occurring disorders, let alone addiction. I stepped into this role and basically created this role for myself and for the department, and obviously for the citizens of Vermont, and certainly for the incarcerated population. So it kind of started with a big bang because at the same time, the legislature had become increasingly concerned with the various pilots that had also been had been directed for the department to do, starting in like 2012, 13, around MOUD in the carceral setting. But they were not happy with the progress we were making. They felt that we were moving a little bit too slowly. So at that point, there were probably about 8 bills in that legislative session. And in my new role, the commissioner sent me into the battle to help wrangle the policymakers, subject matter experts, and all interested parties to get on the same page and to develop something really meaningful, which I think we did. So that resulted in the signing of Act 178, and which charged the department to fully implement all 3 forms of federally approved medications for OUD treatment. It was really my first effort to bring this alive inside of the incarceration space, and I've been at it ever since.
And in your first sort of push to go about making that happen, what was the response and how has it evolved over time?
All good questions. I think the department was interested, but also had reservations. We had been providing, through some of these pilots I mentioned previously, we had been providing buprenorphine only, maintaining to different populations in different parts of the prison system. We have 6 different prisons, and that we're an integrated system, so there are prisons and jails. And so I think that they were very concerned about how wide the door would be opened. But in working with the leadership, I was able to influence them to see that we needed to really step outside of our comfort zone and to do what was right, that this is healthcare, and we can't deliver healthcare to only some people regarding their legal status or any other parameters. I really felt very strongly that if we were going to do this, we needed to do it correctly, which of course has been proven by the DOJ and ADA rulings, et cetera, but I really pushed us to go all the way. I wanted this to be the same for incarcerated people as it was for people who are not incarcerated. And that's the spirit of the law. That's actually how the law starts. It basically states what the definition of opioid use disorder is. It then follows with the definition of what OUD treatment is, and then it basically proclaims that the Department of Corrections will provide exactly the same treatment for incarcerated people as for free people. How it's evolved, again, it's just been messy with COVID and so many different drivers that have tried to push it underground. We fight for it to come back on top, et cetera. It's been a very iterative, deconstructing, constructing type of process. We have also, during that time period, gone through 3 different contractors. So all the healthcare in Vermont and Vermont prisons is provided by healthcare contractors. So there's also that space to negotiate. And they have been willing and unwilling in different points in times. And the contract environment itself has also changed. I feel the contract we have right now is absolutely state of the art and really encompasses my vision for co-occurring and whole health. So that's the strongest it's ever been. We're hoping that this current partner who started in July is also going to be with the same philosophy and the same understanding, so that, we are really all pushing in the same direction. Really granularly, I think what's changed over time is, for some people, their stigmatized beliefs, attitudes, and the way they behave has become entrenched. And then I think for others, it has been sort of a liberating process. They might have been against it in the beginning, and then they've kind of gotten on board. And obviously, the early adopters and the beyond early adopters, the innovators, are extremely happy with this work. So I think it's a normative distribution of all of those. And I'd say that goes across, whether it's security, DOC leadership, whether that is actual healthcare leadership, nurses. Many people were trained a long time ago, and this just does not fit into their rubric of what they believe in. And then there are other people who have had lived experience and or other training experiences, real life experiences where they embrace this fully.
I really appreciate you highlighting the importance of contracting in this process. Was it simply trial and error by which you sort of arrived at where you have today? Was there anybody or anything you could point to in terms of helping other states or other communities think about contracting? Or is it really just a process of really making mistakes and then sort of correcting along the way?
For at least for me and my team,
Yeah.
because we had embraced such at the time was a visionary implementation. It was guided by many pieces of federal legislation and also global policy, medical policy. So, that's what we were always going for. I think the issue for me personally and my team was that when this Act 178 rolled out, we were in the middle to the end of an existing contract. They had participated in a lot of the testimony, but their corporate level was not on board. And so we had to issue a lot of legal position papers and had to really maneuver to force them to get to the table. And that presented a lot of complications. I mean, it was definitely bumpy in the beginning because, as per their testimony, they were well aware that this was all being negotiated. There were no secrets. But then at the end, it was not, we didn't come together. So I actually ended up rejecting the policies and procedures that they promulgated and said that they would simply follow the ones that I had created with others, because that actually reflected the law, and what they were proposing did not reflect the spirit of the law.
You also spoke about stigma and how that in some ways has improved and in other ways has become entrenched. Did you have an intentional training effort, particularly for maybe the correctional staff, that you put in place along the way? Or would you attribute the changes more to seeing the progress that people were making as a result of being on medication? To what do you attribute the positive gains in stigma reduction?
I don't have a good handle on that. I think it's, my experience in this work, and I've been at this for a long time, whether it was I worked in the community before I worked in the prison system, is just like with any change on a systemic or, meso, macro, micro level, it really is a combined process of the head and the heart. And I think for each person, how somebody experiences that learning and changing a philosophy and approach is unknown. It's like we all think that we can control this, but we also know that information alone does not change behavior. It doesn't change attitudes. We certainly did have training, efforts. I myself train at the Correctional Academy. Every time we have a class, I do go do a full day, and part of that is training about MAT and OUD and SUD, etc. I always see the same distribution in each class. Some people are raising their hands saying, oh my God, my mother, father, sister, brother, whoever is on methadone, it's changed my family. We're so much happier. He's not incarcerated anymore. That's why I'm going into this field to help others. And then other people raise their hands and say, this is the devil's work. You're addicting people. And, they've come into it with that experience. And so then jiggling that loose is really complicated. So I guess that's really my honest experience and answer. Training alone does not change behavior or attitudes. And bias exists. And if people want to hold on to their bias, it's like if you try to, liberate that, they experience it as, motivational interviewing, they experience it as you're coming at them. I always try to understand. I elicit information. I walk through and I tell all the correctional officers, I'm Annie Ramniceanu. I'm probably the person you don't like because I'm the charge of the MAT program. Please come and talk to me. Let's have it. And they come up to me and I invite them to tell me everything they want to say without recrimination. And they do. And I listen to them and I say, thank you. So I hope in my small part, at least by showing that I'm open, they can at least say, well, the lady who's in charge of that actually listened to me. And that might be the beginning of some kind of change in their attitude. I don't know.
What's the single biggest advice you'd go back and tell yourself at the beginning of this journey, looking back?
I think that, again, because there are layers to the way we do it with the contractor, I don't know if I could have done anything differently. Honestly, believe me, I have turned this over in my head so many times. I thought that the contractor had bought in. And I think that the people, this is another interesting thing about working with a healthcare contractor in prison. There are the regional staff, and then there is the corporate body. So they're actually serving two different bosses. And it's like having parents who are divorcing. One parent is saying one thing and the other parent saying the other thing, and that person in the middle wants to keep their job. So I think if there's anything that I learned, it was that I didn't quite understand that even though the people on the ground that I was working with were saying yes, yes, it didn't come out until after the law was passed and the corporate entity really started paying attention to what was happening because we were a unique part of their portfolio with this piece of legislation. I think they'd kind of blown it off. Then they came in, and then that's when I had the problem. So that is really the learning, and it was a painful one. And so they probably should have been brought in way before. But my guess is they probably would have hidden and told us what we wanted to hear because they're just going to massage this politically. And then there would have been a hard stop at the end, regardless. I mean, an example of that was in the clinical guidelines that they gave me to review. They only wanted to provide methadone to someone if they had proven medically that they were allergic to buprenorphine. And I wrote back and said, this is not even any medical guideline anywhere in the world. That's not even a thing. I don't know what you're talking about. I reject this. But I mean, that's literally what I was up against. They wouldn't even prescribe methadone, even though the law clearly said you must continue all medications. And if somebody needs to be inducted on methadone, you must facilitate the referral to the hub system and you must make this happen. But that's what they came back to me with. We're simply not doing this at all unless somebody's allergic. Well, nobody's allergic to Subutex. That's ridiculous.
Well,
So
I appreciate you sharing your experience and your advice.
yeah,
You've come a long way.
yeah,
And
yeah.
so I appreciate you sharing your experience in Vermont with others. Where are you all going? What do you see looking out into the future?
Well, so I just did a very interesting call with some contractors who were working on a project on behalf of SAMHSA. And I was getting some education about a federal DEA regulation that we all believed was new, promulgated in 2022. So I have just taken this to my state opioid treatment authority, who I work very closely with, who's in the health department. And basically, if I understand correctly, this regulation says that if anybody in a carceral setting is receiving treatment, active treatment, or any other kind of health disorder, that physician may also prescribe or actually dispense methadone to that person. So I am very interested to see. I was unaware of that. I thought that it could only be prescribed as an emergency medication in a hospital setting one time in a lifetime. But apparently, there is some new language here that SAMHSA is gathering through this survey process, is understanding that state correctional officials like myself don't know anything about this. And the DEA hasn't really met to talk with any of us. So that is definitely something new on the horizon. We are also looking at implementing, at least at one facility, a medication dosing unit which again is a new DEA opportunity. Looking to do that funded by some of the settlement funds coming from the state opioid settlement activities. And we would be looking to do that in partnership with one of our community-based hubs at one of our most northern prisons, where just over time, there are more methadone treated patients there than any of the other facilities. So a dosing unit and that kind of collaboration would obviously make a lot of sense in terms of efficacy and treatment improvement for those patients. So those are two things we're looking at. Also looking at potential research with Indivior regarding Sublocade. We have a standing agreement. I believe that the structure is an MOU with the University of Vermont. The grant or contract structure is such that we can add on other projects. I'm working with the lead researcher there, Dr. Eli Klemperer, to examine that further.
Terrific. Sounds like you will have a lot ahead.
Yeah, those are three things we're very interested in.
Thank you so much for taking time to speak with me today.
You are welcome.